Exercise is one of the most common treatment suggestions for back pain. Yet, how much does patient adherence impact on their recovery, and what are some of the other factors that may influence the outcome as well? Well, on this episode of Clinical Communication, I'm joined by Lianne Wood, who is a senior research fellow at the University of Exeter, and she's also an advanced practice physiotherapist as well. And on this episode, we're discussing two of Leanne's recent reviews on the topic of exercise adherence and back pain. We're discussing what factors can influence the outcomes for exercise adherence with back pain, how much does the adherence actually matter to outcomes, and how much can we really tell from the literature about exercise adherence so far. If you found this useful, please do go and share it with others. Please do subscribe. You can find Lianne on LinkedIn and X. I am at BYBrowPhysio across social media. I've put the two links for Leanne's papers in the description below. As always, thank you for watching or listening, and I'll speak to you soon.
No, so the first review was quite a different review style in that we did something called a realist review. And realist reviews, so adherence happened to be an outcome because we didn't pre-specify what our outcomes were. We were looking to see what were the contexts and mechanisms associated with exercise prescription. And when we started speaking to patients and looking at the literature to try and design the study in a little bit more detail, we found that kind of adherence also could mean engagement, but they weren't um, completely the same thing, but sometimes some people use the word engagement, sometimes the text use the word adherence. So we looked at kind of what were the factors that may have enhanced people adhering to something or engaging with something or taking part or continuing to do something. So we looked at those factors and the clinical outcomes, but we couldn't find the cross linkages across all three, if that makes sense. Um,
Was that expected in advance? Like why they it wasn't they didn't always connect?
no, so realist reviews are you'd call them iterative processes in that you work, it's different to a systematic review in that you have a theory, obviously, to guide you in terms of having some sort of constructs that you're looking at, but you're working with your patients and your clinician expert groups to define and refine that in more detail, and essentially prioritizing where the searches are going. So the whole aim is to try and unpack, well, what are the contextual factors that might be driving whether people do or don't relate to this. So in terms of exercise prescription, I wanted to know more. I'd done a mediation analysis before looking at
Mm.
mechanisms and how did exercise work. And in that process of doing the mediation analysis, realized that there were really few mediation analyses out there, which
Yeah.
meant that actually our understanding of the kind of mechanistic framework of how exercise worked was actually
Yeah.
quite limited. So
Mm.
going to a realist review to say, let's just crack open the box and say, well, from a behavioral perspective, how might exercise work? Let's try and see if we can pull out these theories from the texts. So essentially, you're looking for anything that's suggesting there's a kind of mechanistic relationship. Um, so we weren't sure what we were going to find, is the honest answer, just when we started. Um, and so we found three key mechanisms, which were your trust, motivation, and confidence, or kind of credibility, were the three kind of key mechanisms through which exercise prescription appeared to work, if you can call it that. But they all had different relationships with the outcomes that were clinical outcomes of improving, getting better, or adhering or engaging with exercise, adhering to, engaging. So it wasn't what we expected. Again, theories, trying to test them in the literature is one thing, but we weren't sure what we were going to find.
I guess we should, of those three, you said about confidence, trust, motivation. If we start with trust, I think sometimes people inherently assume, oh, they must trust me as the healthcare clinician. If I listen, they'll trust me, and if I build some rapport, they'll trust me. Um, and as well, no, put back pain and exercise to one side. Even just trust across healthcare seems to have generally lead to better outcomes if you compare to not having
Yeah.
it. Is it a hard thing to measure? Trust?
Yes, I would say so. Um, for the most part, trust in the studies that we looked at used it as a component of the therapeutic alliance, so that relationship. Um, I think you're spot on. I think there are quite a few studies, and increasingly, trust is being shown to be a real cornerstone of um, clinical or medical practice. Essentially, that you know it's an integral part of people telling you the truth about what's going on or not. Um, and probably the corner part of us being able to undertake a holistic assessment, to try and really understand what are people's beliefs. They're not going to tell you if they don't trust you, if they don't like you, they're not going to tell you anything more. They're going to tell you what they think you want to hear. So it's really, really important, I think. And we found certainly in this review that there was two different parts of trust. It was developing trust and maintaining trust. So again, they're different things. You can develop trust, but if you never see the person again, you're not going to maintain any relationship. So if you see them a year later, it's gone. You've got to start again. Um, how to measure it is tricky. I think there are some therapeutic alliance measures that people can use to quantify it. But I would probably say that how people complete a questionnaire like that on a relationship, you can have good days and bad days with different people, depending on what the last conversation was you had, that they told you something you liked or didn't like. Do you know what I mean? Like, so I think it's a really hard thing to quantify or
Yeah.
measure.
It's, and I presume most of the, if I've got this right, most of the therapeutic relationship outcome measures and for rapport and stuff like that all come from psychology. Is that right?
Yes. Yeah, as far as I'm
Um,
aware.
Never been completely ported over. And I think they've tried to develop some now for different professions, right? Some for doctors, some for physical therapists, etc. But I presume, like you were saying about earlier, like different ways of measuring adherence, there's different ways of measuring trust as well. And we can't just, or rapport, sorry, and we can't just, assume they all mean the same thing.
Completely. I mean, you're right. They are tailoring, they're adapting psychology-based ones to therapies and, as you say, physical therapists, doctors. Um, but I think yeah, with all these things, it's been very clear about what do you mean, so is it just rapport you're looking for, that you had a good, the therapist listened to me, or are you actually trying to capture the deeper construct of trust, which is really where you've got a relationship, and that takes
Mm,
time. So certainly one of the things we found was that time was that key enabler. It's not just something that
mm,
happens overnight. It needs
yeah,
time and maintenance to kind of
yeah.
build a relationship, where you have a to and froing essentially.
Yeah, and actually, you're saying about the confidence as well. And that was confidence in that the what was being suggested would help. Is that right? And the clinician's ability.
Oh. Confidence was two different things.
Ah, go on.
Um, confidence could be, so there was two elements to confidence. Confidence could be patient's confidence to do the exercises, as in I know what I'm doing. I feel like I know how to do my exercises, so I'm going to do them. I've done these before, or I've been to the gym previously, or last time my back got really sore, I went to the physio and she gave me some exercises. So I know that they've worked before. I have confidence these will work again. Um, Whereas there was and that's kind of that confidence ties into what we call mastery. So it's like an element of confidence. Whereas the physio confidence there's again two parts to it, of the physio being confident to go, I can manage back pain. I've got lots of experience. I know what I'm doing. I know how to, I've seen this before. I can deal with this. But also the credibility that comes with so patients trusting the clinician because the clinician's experienced and expert and presents themselves in a way that gives them confidence in the clinician to know what they're doing, to treat them, to give that individualized assessment. So it kind of becomes this bi-directional relationship.
We should say now it's not like as you it's the separate things like the there was the picture in the review like kind of the three circles, right, and they kind of interlink.
Yeah,
And like, you can, if you want someone to feel more confident in your approach, they need to feel they can trust you. And then,
yeah,
that kind of then affects the motivation, which we'll come on to. And it's a kind of
completely.
a circle of positivity in a way. Um,
Completely. It's really hard to draw something like this where everything affects everything else to some degree
mm,
because although so it was really interesting is that confidence was only related to adherence as an outcome. It wasn't related to if your clinician was confident, didn't mean that you're necessarily going to have improved pain or physical function from
mm,
the literature, but you were much more likely to do your exercises, whereas in trust, all three of those trust affected clinical outcomes, trust affected engagement, trust affected
mm,
adherence, so all of those things were related to trust. But again, there was a lot more literature for trust than there was for the confidence. So but they did definitely interact in
with
terms
each
of,
other.
as you say, trust led to confidence, which led to motivation, because people were more likely to want to do their exercises if they felt confident that they knew how to
Yes.
do them,
Yeah.
you know.
And was motivation a guarantee? So if they felt more motivated, that they're more likely to do it? Or is it, again, motivation is subjective in itself, isn't it? A bit like trust.
None of these things I would say are guarantees. Um, but certainly with motivation was definitely related to confidence and related to trust, as far as I remember. So motivation was one of the biggest like mechanisms we uncovered in terms of it had these sub themes within it because motivation again could work in different ways. So you could be motivated because you were supported. You could be motivated because you were going to have a telephone call with a physio in 2 weeks, so you better do your exercises now so you can say that you did them at least once, right? Um, but also then there was that thing of the individualized assessments giving someone confidence, but then feeling more motivated too. And then there was this interesting construct of benefits. So people wanting to feel that they could enjoy their exercises, so really wanting to do them. Um, so I do think that there's a link, but I can't say for sure that they're definite. Yeah, it was definite.
It's all going to be individual, isn't it? What helps one person's adherence will be very different to someone else's, and maybe it's the trust more, maybe it's the how the environment is set up, or other things. Was out of interest, were there things you were expecting to influence adherence that didn't?
Hmm. Not that I'm aware of, would be one thing to say, but again, off the top of my mind, I can't think of anything. But if I pick up on what you said just now in terms of just that individualization, there's real examples of that in the literature in things like one person really likes to go to the gym because they feel that's where they normal people go and they're exercising and doing something that they used to do. And then you've got other people who go, I can't imagine going to the gym because everyone's going to laugh at me and I can't do the exercises and I'm going to be standing with my band and they're going to laugh. So there was that real example of the contrast of people who the same thing could provoke both positive and negative responses.
Yeah.
Um, in terms of adherence, not that I'm aware of, um, in that we probably expected that there would be a real, that very much that therapeutic relationship would influence adherence. My kind of a priori thoughts are, you have a good relationship with your physio, they they've individually assessed you and
Yeah.
prescribed you some tailored one or two exercises, not 15, that are, suitable for your level
Yeah.
and challenging enough, but not too hard, etc. Don't cause pain. You like doing them, you
Mm.
understand why they're good to do, you're more likely to do your exercises. And there is some evidence for that, but the reality is that actually the mechanistic boxes around adherence, I would say, are still quite weak.
Mm.
There's
What does
just
it
there's not a lot. There's four or five observational cohort studies that have got the evidence for adherence.
really? Wow.
Yeah, there's not a huge amount in terms of testing it. And there's a few RCTs that have looked at adherence and clinical outcomes, but then they haven't often looked at the causal mechanisms.
Mm. Well, why do you think that is? There's been do you think we just assumed that the more they do it, the better they're going to be? Why there's so little.
Yeah, I
Uh,
think we do.
uh,
Yeah. Carry on, sorry.
well, it's just you say if we can. You're saying about I'm going to say proper qualities. Maybe that's a bit subjective for me to say, but the ones you're talking about. There's some studies which have just, as you say, they've defined turning up to a class at adherence. It's really, it's a lot more to it than that. But we've just, it sounds like just assumed that over time that if someone does their exercises, they're going to get better. Um,
But, if I go back 6 years, which is when I wrote the grant to do the Realist review,
mm,
COVID was just hitting, and we were trying to do all of our physio interventions online. And the whole reason for doing this was, well, if we're going to do our physio interventions online, how do we know what the active ingredient is? What is
mm,
the thing we've got to big up?
yeah,
Is it our relationship?
yeah,
Is it they need to do more exercises because the exercise is the thing that's going to fix them?
yeah,
Or, are there other things that we need to know about? Because if everything's going to a screen, and at that point we didn't know how long it was going to be like that for, you know, I didn't feel like we had a clear construct of what those active
mm,
ingredients were.
yeah,
Um, and I suppose, so yes, I think that there's been a lot of assumptions made around exercise. We've really just assumed, well, yeah, it works, well, why does it work? Or how,
Yeah.
and essentially with my, when I did my PhD, one of the questions was, well, we know exercise is so good for us from a mental health perspective, from a bone health perspective, from a
Mm,
cardiovascular perspective. And then you're like, but if you look at the trials, like Jill Hayden's reviews, exercise is no better than manual therapy or any other active intervention.
mm,
So why are we not seeing better results? Why are we not seeing these transformative, I'm a healthy person and now like you know, we just don't see that huge effect that we would expect in terms
mm,
of, and is it because it's adherence? People aren't adhering to do the exercise, which has commonly been the explanation or the justification.
yeah.
Um, but given how poorly we measure adherence, we don't really know. And
Mm.
so it's really hard to know. Like, is it dosage? Is it like what are the factors? But there's so many, I think, different explanations that could be covered up, and we
Yeah.
just don't really have clear explanations for them.
I
Yeah.
mean, if we go to the second review, so you did the realist review,
Mm.
and the secondary analysis I was just looking at here of the Cochrane review, so that's much more recent,
Yes.
spring of this year, by those things.
Yes, it was.
For some reason, I had it in my head it was the other way around, but no, this did come very recently. So if I've read it right, there was the relationship, but it was not as, especially the between the outcomes of big improvements and little improvements and relationship with adherence in that was not as much as expected. Is that right?
Yes, you're quite right. So what we saw is that actually high adherence was statistically significant and clinically important, but low adherence was also statistically significant, but a much smaller confidence interval and a much smaller effect, essentially. Now, when you speak to Jill Hayden, who is the lead author of the Cochrane Review, her first caution with this is that actually these 46 trials might be something special out of the 456 Cochrane, trials included in the Cochrane Review because
Wow.
they actually measured adherence. All the other trials didn't measure adherence.
Oh, okay.
So, so are these trials automatically better than the trials that didn't measure adherence? Because actually, so they were showing an effect anyway.
Mm,
They were better designed. They may have been bigger sample sizes. Did you mean that they may have had lower risks of bias
yeah,
than other studies? Which is really hard to disentangle because we had so few studies. It's really hard to do those subgroup analyses that we wanted to do in terms of try and disentangle the effects.
yeah,
Um, we obviously only included trials that were exercise to no exercise, again, to try and keep things simple. So there were about 100 studies, and I think there were about an addition, we could have potentially included an additional 42 studies that compared to a non-exercise arm. Um, but so there's a possibility that these trials themselves had an element that wasn't captured within this review.
okay.
Um, but there was a difference when you compared high adherence to low adherence. There was still a more marked effect with the high group that was statistically significant. So it looks like there is there is something about adherence, but we're not sure exactly how much to attribute to it.
Mm. As was that a surprise? You're expecting a bigger,
Yeah,
yeah, gap?
I would say so. And I don't think we expected the low adherence group to find a statistical significance
Mm.
in changes in pain and function because you don't think, if someone's not doing their exercises, well, of course they're not going to get better. But
Yeah.
there they were. So,
Has there been maybe asked this the wrong way around earlier. Was there any, I mean, that's a very recent study, was there any pushback? People saying, oh no, surely if the more they do, the better it's going to be.
no, I mean, they wanted us to clarify and double check. So when we first submitted the paper, we hadn't compared the high group to the low group. We just
Mhm.
said, well, these are the findings that we found. And they said, well, can you just clarify and check that there are no, between those subgroups, let's use the low group as the reference group and compare between that. So that was interesting to do that. Um, but certainly it wasn't an expected finding, no.
Mm.
And the reviewers weren't they were quite supportive of the paper overall, so that was good.
Do we know what it, might not know, but any ideas what it was in the low adherence group that still got them the benefit?
Well, given that most of them were attendance adherence, we're not sure what their actual adherence was. Yeah. So this was them coming to an exercise class. So we can only assume that therefore they were attending and therefore doing the exercise.
Mm.
Um, or non-attendance of those exercise classes, they may still have been doing their home exercises. So, attendance as a proxy for adherence may still not capture, because you might have someone who's a really good adherer, they do their exercises every day, but they couldn't come to those 5 classes because they were on holiday, or
Yeah.
something happened, so they could still be doing their exercises. So
Mm.
I suppose I still have an innate problem with use of attendance as a proxy for adherence, because it just doesn't tell us what's actually happening.
I mean, there's been some studies which I guess are a bit controversial around adherence. That's where they do it covertly. Whether it's, I've seen one where they have it inside some resistance band or ankle weight, that's it, and it kind of
Yeah,
counts, or other ways, which, well, I've only known of two. Are there any more? I can only think of
I
a
don't know of any
handful.
of those, so that's really
Ah,
interesting. So I haven't clearly explored very far into this realm at the moment. Um, the only studies that I'm aware of in terms of was comparing objective. So Philippa Nicholson, who's based at Oxford, she looked at did a comparison of objectively like a accelerometer compared to, or pedometer type thing, compared to a self-report diary, and looked
mm.
at the association, so how well correlated they were. And they were absolutely, like, they taught the patients said that they were doing so much more than what they actually did. So basically, they said you can't rely on self-report measures, which was not really helpful, but really interesting just in terms of that um, intrinsic self-report bias, where people want you to think, if you ask them to do a nutritional diary, you're not going to get a true reflection of what they actually ate, because they just will skip out the second cookie, or, they might write one, but they won't write all three or whatever. Yeah.
How is there ways that would be a better way to track adherence that's possible at this time without
So
spying on them?
Well, increasingly we're using things like activity monitors. So, like, there's a hipster trial going on that Tim Holsgrove's running in Exeter at the moment, where they're using pedometers. So they do, a week of a pedometer,
Mm.
where you're expected to wear it for, I think, 75% of that time, and then they send it back, until the battery dies. Send it back to the team, then they pull down all that data, and the same thing. So you can get a good measure of then kind of walking activity and kind of activity bursts during the day,
Yeah.
but it doesn't tell you as much detail, granularity around exercise, dosage, duration, etc. But you'll get overall physical activity. So those seem to be the preferred go-to measures at the moment that I'm seeing in a lot of the trials I'm working with.
Mm.
Um, but again, it's not quite as good. The alternative option is using smartphones. So trying to use people to do smartphone logging and activity use. Um,
Mm. So the pedometers that include, so like Apple Watches or like
yeah,
things on your hand.
exactly.
Um, is
It,
there out of curiosity with all the with this with the adherence literature, was there any, we talk about, drugs companies and bias. Is there any exercise bias, if we call it that, where someone's, for lack of a better term, you might think wanting a certain outcome?
as in the clinician or the patient?
The investigators.
Oh, of course. I mean, investigators want their people to be doing the exercises that they've given, right? They want them all to be like more than 75% adherent. I think the problem is just that it's a complex issue. Like,
Yeah.
the to give you a story of one of the ortho geriatricians I worked with in Nottingham, um, he always told the story of, on the spinal ward, he managed to get some funding. He got a credit card, that, so basically like a little microchip that you could stick on someone's thigh with plaster. So it stayed on there for 3 days. And basically, when they were having, they'd have a surgery, and then they, the long stayers, essentially, he got funding to give them some bicycle stuff and create a gym up on the ward so people could come and do their rehab and get home quicker. And he got all this funding,
Yeah.
got it all set up, and they were like, "No, I'm here to rehabilitate. I'm here to rest. This is my resting time."
Oh, the patient.
Yeah, did not want to do it, had no interest in getting out of bed.
Ah,
And, we're very happy to wait for the nurse to bring them everything. And so he couldn't get
ah,
them to get out of bed, and change their belief that coming to hospital was required, like that they had to do the rehab to get out of hospital. They were like, "No, this is my protected resting time. Don't interfere with it." So yeah, so I think it's complex. I think there's a real um, beliefs are really firmly entrenched in how people respond to these types of studies.
mm,
Um, and what we'll find with them. Um, yeah, I think I think they are complex on many levels.
I often ask about the future, but I'll bring this in now. Could that be the next step in where we kind of move forward with these kind of things, with not just exercise and back pain, but what it is that helps someone move forwards? Because we talk about behavior change a lot, which this
Mm.
is. Um, but if someone can change their behavior, but if their beliefs are still there, whatever the belief is, we all hear the story that someone will come and say and they've got their view that their knee arthritis is bone on bone, blah 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 blah, and they say, "Oh, I did all these exercises, I've been doing it, but at the end of the day, it's not going to change it. I need to have it replaced."
Yeah, and completely. Like my sense is that's we can't change behavior not meaningfully without changing beliefs.
Yeah,
We have to start there, and that's where that kind of individualized, holistic understanding relationship and that trust to really be able to understand what does someone really think about that. Because if they tell you it's codswallop or whatever, they're not going to do it or meaningfully engage with it. They'll do it because it makes you happy, so they can say, "Oh yeah, I did my 5 exercises." But
yeah.
really understanding what drives that patient and to be sat there in front of you, the fact that they've come back, um, understanding what they wanted to get out of it, understanding their expectations, their beliefs about it is really, really important because you won't change anything until you can get to that, I don't think.
Well, is there? I realised that your reviews on Adherence as well related. Um, was there anything about beliefs and I say outcomes of exercise that's there so far, where we've actually tried to like shift them?
Certainly more and more I think there's been quite a few trials actually looking at beliefs now more increasingly. Um, and I suppose in terms of, you look at again, the mediation analyses that have been done
Mm.
have looked at fear avoidance, pain catastrophizing, self-efficacy. Those have been the key things that people have looked at trying to change. Um, so fear avoidance being probably the most commonly assessed one. Um, there are some other ones around beliefs, but those are probably the proxies we use for beliefs, I would say, unhelpful beliefs.
Yeah.
Um, and I think increasingly we're seeing that, so there's been probably been more now, but there were about 8 to 10 mediation analyses that have shown those have got relationships with outcomes. So, particularly for exercise and chronic low back pain. So I suppose that suggests to us that actually those beliefs are really, really important and we should be prioritizing assessment of those beliefs in our consultations.
Yes.
And I probably still don't think we're there yet as practitioners to be assessing them well enough.
Mm.
Um, we there's some interesting master's projects going on at the moment of students I know of who are looking at how clinicians, MSK clinicians assess beliefs in practice. And although a lot of us say we're doing a biopsychosocial assessment, we're not really in practice. So I
Mm.
think we talk the talk very well as
Yes.
clinicians, but changing our own behavior is probably the first place to start.
Yes. Which does rely on what you were saying earlier, which is time. Um,
Yes.
if I'm 20-minute FCP, that's tricky. If an hour,
Yeah,
but if I'm me in an hour in a paying service, it's more doable. Uh,
completely.
did that out of interest? I realised a lot of them were group sessions, but anything that was individual, did uh, time with clinician in,
In
have
the
an impact
adherence
on those
one.
outcomes?
In the adherence study,
Yeah.
I don't know, to be honest. I don't think we looked at the difference between group and individual. Again, purely because we were underpowered. We just couldn't, because the groups are so small between the low, high, and moderate, we
Mm.
couldn't subgroup accordingly.
Okay.
But it was something we had wanted to look at. Um, yeah, so I don't know is the answer.
Were there things about your two reviews that you wanted to say that I've missed?
No, I think I suppose that what I feel impassioned about these two reviews is just asking clinicians to think a little bit deeper about what they're doing in
Mm.
practice. Instead of just saying, here's 5 exercises, these, oh, you've got knee pain, I'm going to give you my usual 3 exercises, off you go. Yeah, oh, you've got back pain, here's my nerve slider, and you're this one that I'm going to give you because I give everyone with back and leg pain these 2 exercises. I think it's really important as clinicians we take a step back. You can still give those same 2 exercises, but with a caveat that you say to the patient, this is your problem. This is why this is limiting you. I'm going to give you this exercise because it's going to help you put your shoes on in the morning, and that's your biggest problem that you told me. Do you know what I mean? It's got to be tailored and individualized. Others, it's just meaningless, and it'll be another piece of paper that goes on their
Yeah.
pile next to their bed. So I think making as clinicians and as physios, where we probably are really, fighting for our corner right now, certainly in the UK health system and probably worldwide, I imagine, I think these challenges we face are all over. I think it's really important that we think about what we're trying to achieve, what we're trying to do, and how we're doing it.
Mm. Yeah, what are the effects, so to speak, the bits of the source that make the outcome beyond just hoping they'll do something.
Yeah,
Yeah.
yeah. And not just being on autopilot, just really thinking about it and trying to really engage with that person in front of you. So really um, making it meaningful for them.
Yes, relate. You said it I think in both of them that the more it was tailored to the person, the
Yeah,
more A, they would likely do it, and B, potentially have better outcomes with it.
completely. But we all know that, you're not going to.
People know it, whether it's done or not is more variable, as you say.
Yeah, yeah. It's really tricky. I think, it goes back to what you were saying earlier. Like human behavior is complex. It
Mm,
really is complex, and people do things. There are a number of things people do without thinking, and there's a number of things that people won't do without thinking. Do you know what I mean? Like, so there's
mm,
that thinking component has to come in there. But the reality is, as you say, when we're busy clinicians and you're on your eighth person and the first one ran late and now you're playing catch up, it's really hard to sit down and go, right, I'm here present with the person in front of me now,
mm.
and I'm going to give you all my attention and tell me about yourself and why you're here today, and just slow down and give that space. It's really hard.
Yeah,
Um,
yeah, yeah, especially if you, yeah, as you say, had a long morning and want to make some, yes, and if you're running late, yes, all the things that sadly happen that sometimes you can't control, and
completely.
eh, you just have to sometimes you have to be present and see where it goes. Um, it's particularly hard. Not that I'm in this role, but I presume if you're only ever going to see them once, if you're in that kind of
Yeah.
triage, uh, whether it's first or advanced practice role, where you're seeing them make well, hope you make a shared decision and then goes off wherever,
Yeah.
and you don't you have to get the certain things done within that time, rather than hope saying, well, you can come back next time and we'll do
Yeah.
X, Y, Z.
That holds. And I suppose that does hold. I suppose the only thing to say with that is probably in an advanced practice role, then they may be less likely to be providing exercises. But
True.
equally, they should still be doing that shared decision making and individualized assessment. So you'd
Yeah.
like to think that they would have that base platform, created irrespective.
Now, Leanne, ask everyone this, and you can give one example, two, or a different type. But ask everyone, what's been one of your hardest clinical conversations?
A classic question, this.
Yeah.
um, I had a good think about this because the first thing that springs to mind is, oh, giving a bad diagnosis. But I actually thought it's probably not one of my hardest. Probably my hardest is when you as a clinician really, really can see that you can help someone and they are really resistant to wanting that help.
Mm,
So they're just so entrenched in their beliefs that they just don't want to hear what you have to say. Um, and that's probably my hardest because I really want to help that person in front of me. And I feel like I've got all these things I can share with you.
yeah, yeah,
And if they just don't want to connect with you and you just kind of keep hitting a barrier,
yeah,
um, I find those really hard. Someone is like, no, you know, it's the Spurs. I just need a new knee. Nothing you can say or do is going to change that. Just send me there. That there's an element of, particularly if their X-ray isn't bad or their MRI isn't bad, and there's
yes,
that they actually probably aren't going to be, or that they've got other kind of factors that are really going to, I mean, they're probably likely to have a really bad outcome of surgery, or are not going to be offered surgery, so they're just going to bounce around for another year or so. Um, I think those are really hard when people almost just aren't at that place to receive, like, or to allow you to kind of support them. Um,
Almost trying to break and say good news, but it's bad news in a way
yeah,
because that's the kind of the unspoken part of we talk about like normalizing imaging findings. Like someone has a some stuff on their scan, but it's not. We can say, oh, it's normal for your age and all that stuff, which is supposed to be hopefully reassuring. But for some people, that's not what they want to hear.
yeah.
They're hoping that something will come up that they can be repaired or injected or whatever it is that will then fix said issue. Even if we think it's good, to them it might be bad. I guess it fits with the beliefs we were talking about earlier.
And I think the challenge with that partly is I think I would say I've definitely got better at delivering that news and accepting the fact that people don't want to be helped, and I'm okay with that now. But it's
Mm.
certainly at some points in my career I found that really, really hard to take. Um, but also I think now I see it that I'm happy to send them on for that second opinion, but I'm also aware that there's a chance that they could see someone who'll say, "Yeah, sure, I'll operate on you." And you'll be like, "Wow," like they could still end up getting a really
Yeah,
bad deal of the situation. In research now, I do a lot of working with patients and hearing their stories. And of course, the people who tend to volunteer to come forwards are probably the ones who've had the bad stories.
yeah,
So you
yeah,
hear a lot of sad stories where people have really had just really difficult journeys or now have got a very difficult journey ahead. And yeah, I think those you can't guarantee everyone's going to practice by the best evidence-based medicine approach. You just
yeah,
a lot of people do just carry on doing what they've always done.
yeah. Yes, there's been some examples where someone we had who was moving forwards very nicely, and then it's the classic example of someone they get told, "Oh, your scan shows this," or "we can," and then they get us told, "Oh, well, we could do this thing," and I'm sat there thinking, "No, please don't do said." Um, and you
Yeah.
can see how this is going to end out, but they're gone.
They're
Like,
gone.
yeah,
Yeah. You know,
um,
you, yeah,
you can see how this is going to work, and you almost then have to wait for them to go through the journey. Um, because I know I could say, well, all this evidence shows X, Y, Z, but if some, I don't know, person has offered them some procedure, whatever it is that's going to offer them the solution, even though it probably is unlikely to, naturally as a human, you're going to pick that. You're going to want to lean
of
towards
course.
that because that's the positive,
Completely.
the hope.
Yeah, it's really tricky. And yeah, it's really tricky. I find those things hard in that you don't and you don't know what's best for that person. You can only work with what you
Yeah,
can read the best of the literature and saying, well, this is what I can see is suggested that might be better for you, but you can never know what the best thing is. I mean, it's just you can only hope that person has a better journey. But you also don't want them to come to any harm.
yeah. And thank you for sharing that because it's important. Obviously, we talk about trying to help people work with their values and what's important to them, but sometimes it needs to be the right time
Yeah,
for them.
completely.
Uh,
Completely.
we said about beliefs earlier. We said about packables. Is there anything else that's kind of in the future for adherence research?
Better ways to capture it and
Mhm.
people measuring it, just actually measuring it. So um, I don't know what that looks like yet. I don't, whether it's just still is a simple question or whether it is wearables and um, home exercise logs. So I think one of the better ones we had in this study was a home exercise log and a self-report diary and some attendance. So they use both as a kind of combination. So perhaps we've got to look at some sort of combination of measures. Um, but certainly as researchers, we need to measure it more. And I suppose as clinicians, my question would be, do we capture adherence within our notes or in our
Yes.
assessment? Because I'll put my hand up and say I didn't write it down always. Sometimes I did, but not always. Um,
No, I don't think. Well, and it's one of those things, as you say, even if they self-report it, how accurate is it?
yeah, it's just unreliable as a measure by itself, isn't it? So we need something more reliable.
I don't know if there's any products yet where they're that may be one thing in the future. If you have a patient with some form of wearable and you have your electronic note system and they can somehow pair them up.
Wow. The NHS is a long way off that.
Well, it doesn't have to be their wearable, but some form of like, well, it's not one you give them, but their wearable that they've
Sure,
bought.
sure. Yeah, yeah.
I don't know. Who knows?
That'd be
Leanne,
great.
thank you for discussing this with me. You're on LinkedIn, where we met,
I am, yeah.
and X, easy
An
enough.
email.
And people, obviously, all the research is online. I presume you've uh, what's the website called where you can everyone has the kind of uh,
Oh, ResearchGate.
ResearchGate. That's what I'm thinking
Yes,
of.
I'm on ResearchGate too.
ResearchGate. So and people can find you there as well. Are more papers becoming open access compared to years gone by?
Definitely. So I'm part of the University of Exeter and we have an open access policy. So all of any publications that we do, usually our preprints are open access as well. So if you go onto the University of
Mm,
Exeter's website, we'll have our any papers that published by University of Exeter staff should be open access in that sense.
right.
It might not be the finished product, the polished piece, but it might be the accepted version or something like that. So
Mm.
yeah, so different universities have got different policies around open access.
Do we know why this is? Was there
Trying to
opening?
make research more inclusive and accessible.
Okay, okay. And the journals haven't kicked off too much yet?
Well, it's not the finished product, and authors have the right to share their finished products with people who do ask. So,
Oh, do
if you
they?
wanted, so
Mm,
if you ever wanted a copy of something that you don't have, you've got a paywall against, if you email the lead author, they should be able to share it with you. Um,
mm,
yeah, so authors have still hold the rights of that paper. Um,
mm. There we go. I'll tell you what. We'll leave that people, let people now go searching away and go into their data banks of the
Sending
papers
him
they couldn't
email.
access. And just the lead author, right? They can't go to the other ones?
Well, it'll be the corresponding author usually. I mean, to be fair, when I've looked for data before, I have emailed almost every single author on our author list before, but it doesn't always guarantee a response.
Oh, I'll keep that in mind. Cool. Leanne, thank you very much for your time.
No problem. Lovely to meet you, Ben.